already know. Alright, chapter 24, environmental emergencies. This is a pretty big chapter too. It's 162 slides. And talk about heat and cold emergencies, exposure to heat and cold. Exercise-associated hyponatremia, bite stings, lightning strikes, and high-altitude sickness. Alright, EMTs, Seth and Steve. I was going to say Holly. Seth and Steve. Y'all shut up. Can feel the cold and wind despite their heavy winter gear as they head towards the center of an empty field where a police officer and bystanders are surrounding somebody on the ground. Well, I hope there's really nothing wrong with them. They're just standing there. I'm glad you're here, says one of the bystanders. This is Stan. We haven't seen him since last night. We found him here this morning on our way to get breakfast. He's freezing cold. Well, I imagine he is. Y'all put a blanket on him or anything, for God's sakes? How should they organize their priorities in managing this patient?
Getting his temperature up.
All right, what findings should they anticipate in this patient?
Hypothermia, maybe?
What emergency care for this patient?
Rapid transport.
Yep. All right, we're going to learn considerations for assessing and managing patients who have suffered from environmental emergencies, including exposures to heat, cold, as well as bite stings and altitude sickness. All right, your body maintains a temperature of 98.6. You have thermoreceptors that send information to the hypothalamus. The hypothalamus then sends signals for adjustment to maintain your body temperature. Heat exchange with the environment by a thermal gradient in which warmer temperatures move towards colder temperatures. The body responds by increasing or decreasing the amount of heat produced or lost from the body. Behavioral regulations, which is input from the thermoreceptor, provide information to the brain regarding the patient's comfort level. The patient makes a conscious effort to change the sensation and comfort level by taking some action. If too hot, the person might take off clothing, spray cool water onto themselves, fan, or perform some other behavior to attempt to cool themselves. The patient is too cold, they might add clothing, stand next to a heat source, get out of the colder wind, or move about to increase their muscular activity to produce heat. The body must maintain an optimum body temperature so that cellular function can continue normally. If at any time the body cannot compensate for the heat that is either gained or lost, the resulting cellular and organ damage can lead to an environmental emergency. The body relies on three systems: your skin or your integumentary, cardiovascular, and your respiratory system to help maintain a normal temperature when the body becomes too warm. Alright, when the body loses more heat than it gains or produces, the result is hypothermia, or low body temperature. Heat loss occurs through 5 mechanisms. You have radiation, convection, conduction, evaporation, and respiration. Alright, we'll go in and talk about this wind chill index, like any of us know anything about a wind chill. Anything that speeds movement of the air, such as the wind, also speeds the cooling process. That is where the concept of wind chill comes into understanding and predicting hypothermia. The process in which a liquid changes to a vapor is called evaporation. Evaporation has a cooling effect. When body heat causes the body to perspire and the perspiration evaporates, the heat that has been absorbed by the sweat is displaced into the air and the body surface is actually cooled. When the amount of heat the body produces or gains exceeds the amount the body loses, the result is hyperthermia, or a high body temperature. Alright, hypothermia is when your body core temperature reaches below 95 degrees. You usually go into a coma at 78 degrees. Alright, your mortality rate is as high as 87%. It can have a sudden onset when someone falls through ice, or a gradual onset, such as prolonged exposure to wind or Thermal control, the capability of the body to regulate its temperature, is lost when the body's temperature is lowered to 95 degrees Fahrenheit or 35 degrees Celsius. A coma occurs when the body's core temperature reaches approximately 79 degrees Fahrenheit. Cases have been documented in which patients have survived after reaching a core temperature as low as 66.4. Death can occur within 2 hours of the first signs and symptoms of generalized hypothermia. Extremely low temperatures are not necessary for hypothermia to occur. It can occur in temperatures as high as 65 degrees depending on the wind chill factor. People who are at the extremes of age, such as infants, especially newborns and toddlers, and the elderly, are at an increased risk of hypothermia. They cannot regulate their body temp as well as most normal adults. People who have recent surgery or have shock, head injuries, burns, generalized infections, spinal cord injury, thyroid gland disorders, and diabetics, bless you, are at an increased risk for hypothermia. Some drugs, alcohol, and poisonings can increase the risk of hypothermia. The longer the time a person spends unprotected in a cold environment, the greater the chance will be that will become hypothermic. Clothing that's inappropriate for the temperature enables a person to lose heat at a greater rate than if they had layers of clothing for a cold environment. Physical activity requires muscular movement that produces heat as a byproduct. Thus, the person who continually moves can generate internal heat that maintains the body's core temperature at a higher level than if they were not moving. So I guess as long as you stay moving, you'll be okay. Or you should be. The elderly have impaired recognition of cold, a diminished basal metabolism, and poor constriction of blood vessels in the extremities. This can lead to a condition known as urban hypothermia, in which an elderly person becomes hypothermic in their own house. Hypothermia can occur with little warning and can progress rapidly from mild to moderate to severe to profound. As core body temperature drops, the body's thermal regulating mechanism and perception become confused. A person, even though dangerously cold, might undress, thinking they are too hot. In water temperatures less than 77 degrees, an immersed person who is not wearing protective gear can't generate enough heat from movement to maintain a normal body core temperature. At water temperatures that are below 68 degrees, the person is at increased risk of dying from either drowning or severe hypothermia. Cold shock response is the first phase of response to cold water immersion. The immersed person exhibits respiratory pattern changes with hyperventilation and a gasp response. Loss of breathing ability if not acclimated, and breathing becomes erratic. Cold incapacitation. If the immersed person survives the initial cold shock response, they have approximately 10 minutes before they become unable to perform any useful activity. They lose their fine motor function first, followed by gross motor function, followed by the inability to perform any useful or meaningful activity. The reason for sudden death within 24 hours following rescue is related to rewarming. Upon rewarming, the circulation of cold, acidotic, or alkali blood back into the core circulation. You have a catecholamine release. Decreased hydrostatic pressure upon removal of the water. Cold baroreceptors that have a decreased sensitivity to blood pressure changes. You have increased blood viscosity. Decrease in intravascular blood volume, and decreased function or pump function of the heart. Body temperature can drop to the water temperature in as little as 10 minutes. In fact, body temperature drops 25 to 30 times faster in water than in air of the same temperature. Do not overlook the possibility of hypothermia in an elderly or pediatric patient who has been subject to the cold ambient temperatures of air-conditioned buildings. A patient in an air-conditioned environment who has decreased tissue insulation and ability to move from a cold surface is a prime candidate for urban hypothermia, even on a warm day. Myxedemia coma is a complication that occurs late in the progression of hypothyroidism and can be fatal. It occurs most commonly in elderly women who present with extreme hypothermia. They can have seizures, slow reflexes, and respiratory depression. Although myxedemia coma occurs rarely in only 0.1% of hypothyroid patients, it is a true emergency, as death from this complication is likely. We actually had a guy from the prison. They brought him over in the prison van. He was acting all crazy. Thought maybe he had overdosed on something, and he was actually in this myxedemia coma. Alright, trench foot, common in military personnel, results from exposure to the feet to a constant cold but not freezing temperature. Immersion foot results from prolonged immersion of the feet in cool or cold water or moisture. This can occur if the foot is kept in cool or cold, wet socks for a long period of time. This is why when you work in the winter, you always carry an extra set of boots and an extra 2 or 3 pairs of socks. The key to your emergency management of non-freezing cold injury is to recognize the condition and to prevent any further cooling or trauma to the extremity. Don't allow the patient to walk or stand on the affected foot or feet. Remove the footwear and socks carefully. Loosely cover the area with dry, sterile dressings. Alright, local cold injury occurs when ice crystals form between the cells of the skin. It tends to happen on the feet, hands, ears, nose, and cheeks. Right? Cold injury requires much colder temperatures than are actually needed to produce generalized hypothermia. You have predisposing factors that can increase the likelihood of a person suffering from a cold injury: trauma, extreme of ages, wet clothing, alcohol, it thins your blood loss, high altitudes. Alright? These cold injuries fall into 2 basic categories: early or superficial and late or deep injury. The injury can involve the whole hand or foot. Swelling and blisters filled with clear or straw-colored fluid can be present. Deep freezing cold injury is an extreme emergency and can result in the permanent loss of tissue or that limb. Early or superficial freezing cold injury. This is frostbite. The patient is usually unaware of the injury, which commonly develops after direct contact with cold objects, cold air, or cold water. Then you have late cold injury. This is also frostbite. The skin is white and waxy in appearance. Palpation of the affected area reveals a firm to completely solid frozen feeling. The injury can involve the whole hand or foot, swelling, blisters, filled with straw or straw-colored straw-colored fluid can be present. Alright, scene size up. Ensure your own safety. Look for clues to how the environment is affecting the patient. Any kind of predispositioning factors. Do they have on wet clothing? Are they dressed for the environment? What is the temp inside the residence? Have they ingested alcohol, been using drugs? Any injury that can interfere with normal thermoregulation. Carbon dioxide is the major stimulus to breathe in the normal patient. Thus, a decrease in carbon dioxide production decreases the drive to breathe. causing the respiratory rate and tidal volume to decrease and eventually become ineffective. The pulse, breathing, and blood pressure are difficult to assess in a hypothermic patient. You should exercise due diligence in confirming the presence or absence of vital signs prior to the application of CPR. Secondary assessment should be conducted in the back of a warmed ambulance. Do not delay moving the patient out of the cold environment to conduct the exam. The patient is responsive, gather a history. My nose is freaking itching like crazy. Alright, factors predisposing people to hypothermia. Pretty much already been over this. Age, drugs, alcohol. Alright, signs and symptoms: decreased mental status, amnesia, memory lapse, incoherence, mood changes, impaired judgment, dizziness, slow, slurred or thick speech, decreased motor sensory, joint and muscle stiffness, lack of coordination, exhaustion, uncontrollable fits of shivering, reduced sensation or loss of sensation. You see respiratory changes, changes in the pulse, skin color, slowly responding pupils, and low to absent blood pressure. Alright, here's the stages of hypothermia and the associated physiological changes. It's in your book, table 24-2. Remove any wet clothing, dry the patient, and use blankets to insulate the patient from the cold. Alright, insulate the patient from the ground up. Get something underneath the patient as quickly as possible. Remember to insulate the head. Protect the patient from exposure to the wind. Rough handling can cause cardiac dysrhythmias, especially ventricular fibrillation. Never allow the patient to walk or exert themselves in any way. Even minor physical activity can disrupt the rhythm of the heart. You want to administer supplemental oxygen to maintain an SpO2 of 94% or more. Use warm, humidified oxygen if possible. If VFib or VTAC persists after the initial defibrillation, it might be reasonable to continue to defibrillate as the patient is rewarmed. Follow your local protocol, continue CPR aggressively because prolonged survival in cases of hypothermia have been reported. Some experts advise active rewarming only if you are more than 15 minutes away from the receiving facility. According to the AHA, active rewarming should be applied to patients with a core body temperature less than 34 degrees Celsius or 93.2 Fahrenheit. Follow your medical direction and your local protocol for hypothermia treatment. Active rewarming is a technique of aggressively applying heat to warm the patient's body and includes these measures: wrapping the patient in warm blankets, placing heat packs or hot water bottles in the groin, in the armpits, on the chest, turning up the heat in the patient compartment of the ambulance. Passive rewarming is taking measures to prevent further heat loss and giving the patient's body the optimum chance to rewarm itself. Passive rewarming includes inhibiting further heat loss by wrapping the patient in blankets and then increasing the heat in the patient compartment of the ambulance. Do not allow the patient to consume stimulants such as tobacco, coffee, or alcohol. Never rub or massage the patient's arms or legs. You could force cold venous blood into the heart, resulting in cardiac irritability and cardiac arrest. The safest rewarming takes place in a medical facility, so transport is the most important factor. Passive rewarming is taking measures to prevent further heat loss and giving the patient's body the optimum chance to rewarm itself. Passive rewarming includes inhibiting further heat loss by wrapping the patient in blankets and then increasing the heat in the patient compartment of the ambulance. Turbulence and activity in the water decreases survival time by approximately 75%. If the patient continues to move or struggle, they can cool more quickly because of the increase in the movement of cold water molecules next to the skin and around the body. You want to lift the patient from the water in a horizontal or supine position to prevent ventricular collapse or vascular collapse and provide spine motion restriction if injury is suspected. Remove their wet clothing carefully and gently. Excessive activity can cause the heart to go into VFib. You can cut their clothing off, alright? Get it out from under them. Put warm material under them. Freezing cold injury that is localized can be difficult to assess. While still frozen, even severely affected tissue can appear almost normal, with purplish or other abnormal colors appearing only when it's thawing. The tissue can be completely numb when frozen, but will be very painful. It will burn, sting, and throb before it freezes and as it thaws. Although you might be unable to assess its severity accurately, you can almost always see a clear demarcation at the site of local freezing cold injuries. Never initiate thawing procedures if there is any danger of refreezing. Keep the tissue frozen is less dangerous than submitting it to refreezing. It's like once you take something out of the freezer and let it thaw, you don't put it back in the freezer to freeze it again. Yeah, bad. It's very, very bad. Alright, if the SpO2 is less than 94 and no signs and symptoms of hypoxia, oxygen might not be necessary. Carefully remove any jewelry or wet restrictive clothing to prevent causing further injury. If the clothing is frozen to the skin, leave it in place. Secure the affected extremity to a spine board or a splint and minimize movement and elevate. No part of the injured extremity should be in direct contact with a hard surface. Cover the area or the affected skin with dressings and dry clothing to prevent friction or pressure. Never rub or massage the affected skin. Never re-expose the injured skin to the cold. If they have a late or deep freeze injury, carefully remove jewelry and cover it. Do not break any blisters or treat them with salve or ointment. Do not massage the affected area. Never apply direct heat to rewarm. Do not allow the patient to walk. Rapid rewarming steps. Immerse the affected part in a warm water bath just above body temperature. Keep the water temperature consistent. Stir the water to keep the heat evenly distributed. Keep the tissue in the water until it is soft and color and sensation return. After thawing, dress with dry, sterile dressings. Place dressings between the fingers and the toes. Elevate the extremities. Protect against refreezing. Transport as soon as possible. Alright, keep the patient warm and try not to re-expose them to the cold. You want to check their vital signs every 5 to 10 minutes. Hyperthermia is caused by an increase in the body's heat production or inability to eliminate the heat produced. Various stages of hypothermia are heat cramps, heat exhaustion, and heat stroke. Heat cramps are caused by electrolyte imbalance to the muscles, most commonly from overexertion in hot temperatures with excessive diaphoresis. You will see this a lot here during the summer. You have people that work outside, especially when it gets like springtime. We don't really have a spring here. It's like cold and then it's hot as 80s. There is no in between. It's either cold or it's hot as 80s. So, these guys go out. They haven't been drinking a whole lot during the winter. They go out and they're working all day. They're sweating. They're not drinking Gatorade. They're not drinking water. They're not doing anything. Alright? So, when they're sweating, their electrolytes are going out with it. So, they need to be replaced. If they will drink some Gatorade or some water with a little bit of salt in it, they'll be a lot better off. Even Powerade. Heat exhaustion occurs when the body's cooling mechanisms have been expended and the central nervous system and other systems start to show the consequences of this depletion. Patients present with dizziness, fatigue, normal body temperatures, and diaphoresis. A patient with heat exhaustion commonly has slight alterations in their mental status, such as dizziness, fatigue. They can have a normal body temperature, but should be sweaty. Okay. Heat stroke occurs when the body's heat regulating mechanisms break down and become unable to cool the body sufficiently. The body becomes overheated, the body temperature rises, and sweating ceases in approximately 1/2 of these patients. They will have an altered mental status as well. Pre-existing illnesses, alright? These are your predisposing factors. Heart disease, kidney disease, strokes, Parkinson's, thyroid glands, skin diseases, dehydration, obesity. The list continues. Any kind of infection, fatigue, diabetes, alcoholism. Exercise and strenuous activity can cause the loss of more than 1 liter of sweat per hour and increase heat production. Exertional heat stroke is the second leading cause of death in high school students. When you do your scene size up, you want to scan the scene for evidence that the patient is suffering from a heat-related emergency. Probably the most important factor to consider are ambient temperatures and humidity. If it's in children, left in closed vehicles or structures that are hot and poorly ventilated are prone to heat emergencies, especially if the infant or child is overdressed and too young to remove their own clothing. Elderly patients, especially those who are not mobile enough to escape their hot environments, are also likely to become victims of heat emergency. High temperatures, especially greater than 90 degrees Fahrenheit, and relative humidity greater than 75% combined to create an environment that renders the body's cooling mechanism less effective. Well, this is like 2/3 of Louisiana's environment all the time. A patient with an altered mental status and hot skin is a high priority. Alright, form visual impressions, assess their mental status, airway, breathing, maintain oxygenation, check their skin. If the patient is in a hot environment, move them to a cool environment as quickly as possible. If they're responsive, gather a history, paying attention to the symptoms of which the patient complains. The OPQRST can be modified to gather further information about their symptoms. Their baseline vital signs can reveal blood pressure that is normal to low. Heart rate and respirations are typically elevated. They will have elevated core body temperature, muscle cramps, weakness, exhaustion, dizziness, faintness, rapid pulse, usually strong at first but can become weak. Initial deep rapid breathing that becomes shallow and weak. Headache, seizures, loss of appetite. Altered mental status. It can progress to unresponsiveness. Their skin is neither pale or moist, or hot or dry. Move the patient to a cool place, such as the back of an air-conditioned ambulance, away from the source of heat. If no cooler location is immediately available, at least move them to a shaded area. If breathing is adequate, administer oxygen based on your SpO2 reading. Remove as much of the patient's clothing as you can. Loosen what you cannot remove. The patient should be kept as comfortable as possible. You want to help cool the patient, but make sure they don't get chilled to prevent shivering, which actually increases their core body temp. Alright, consider raising the feet and legs to 8 to 12 inches to improve blood circulation to the brain and other core organs by reducing pooling in the lower extremities. If the patient is nauseated or vomiting, place them in the left lateral recumbent position. If they're fully responsive and not nauseated, you can have them drink cool water. You want to consult with your medical director before doing this. If the patient is unresponsive, has an altered mental status, or is vomiting, do not give them fluids by mouth. Generally, a hypothermic patient with pale, moist skin that is normal to cool in temperatures needs transport when the patient displays any of the criteria listed. Altered mental status or no medical problem. Vomiting, has vomited, nausea, or refuses fluid. Core body temp greater than 100 and does not respond to treatment. You want to remove the patient from the source of heat, place them in a cool environment, such as the back of your air-conditioned truck, take them inside their house. If breathing is adequate, administer oxygen based on the SpO2 reading, remove as much of the patient's clothing as possible. Maintain your oxygenation. Immediately begin cooling. Blah, blah. You can put cola packs on either side of the neck, under the armpits, in the groin. Okay. Transport immediately. Continue to administer oxygen and cooling methods during transport. Always transport a hyperthermic patient with hot skin that is moist and dry. And you want to consider early ALS intercept. Consult medical direction before giving the patient sips of low concentration salt water at the rate of 1/2 glassful every 15 minutes if possible. Do not give them salt tablets. Try to gently stretch the involved muscle groups when they're having these heat cramps. Some experts advise massaging the involved muscles if it does not cause additional pain. Closely reassess the airway, breathing. Be prepared to establish an airway and provide positive pressure ventilation. Also be prepared to manage seizures. The pulse can continue to weaken or the rate can increase. Correlate changes in the pulse rate with their mental status. Exercise-associated hyponatremia, also known as exertional hyponatremia, and water intoxication, is associated with prolonged exercise or exertion. However, the pathophysiology of the condition is not from an increased body core temperature, but from a depletion of sodium related to water content and severe electrolyte imbalance. Alright, mild EAH is associated with nausea, vomiting, headache, bloating, and edema to the hands, legs, and feet. The hallmark finding to assess for are decrease in mental status, fatigue, headache, ill feeling, and nausea. You do not want to give them fluids. They will projectile vomit and they will seize on you. Alright, EMTs quickly determine that Stan is unresponsive, but that respirations and pulse are present. They immobilize him on a long backboard, put a cervical collar in place, and move him to the ambulance before further assessment or treatment. Once in the ambulance, Steve reassesses the airway and breathing and decides to insert a nasopharyngeal airway and assist ventilation. At the same time, Seth removes Stan's wet clothing and covers him with blankets. Seth puts the heat in the ambulance on high and continues a physical exam. He finds a hematoma on Stan's head as well as abrasions on his hands, suggesting there may be injury in addition to cold exposure. Without further delay, they begin transport. Steve manages the airway and ventilations and monitors the patient's pulse. At the hospital, it is determined Stan's core temp is 89 degrees Fahrenheit. Rewarming measures are implemented as a thorough examination is performed. Although Stan's blood alcohol level is elevated, his injuries appear to be minor. The nursing staff continues to monitor Stan carefully for complications of hypothermia and rewarming. Alright, we'll take a little break.